to the restroom before I was supposed to start at 9 o'clock, and I heard everybody applauding, so I started walking over and see Luke coming out trying to find me. It's great to see everyone. I know that sounds a little cliche, but after the last 2 years of what we've been through, it's really exciting to see, everyone. Perfusion's such a small knit community, and in many ways we're family. There's one level of separation in perfusion, right? And with Kevin Bacon, there's 6, but with perfusion, there's 1. If I don't know who you are, then one of my friends does. And it's just so refreshing to be able to see everyone again. So thank you, Susan and Bill and Luke and the rest of the planning committee for inviting me to present to you today. And presenting on a topic that, obviously is very near and dear to us in terms of blood management. And over the years, the last 14 years, we've really become key stakeholders in developing clinical practice guidelines on the management of blood in cardiac surgery. So what I want to spend my time with today is talking to you about the most recent 2021 STS, SCA, AmSECT, and Society in the Advancement of Blood Management patient blood management clinical practice guidelines. Talk to you a little bit about the methodology and how we develop those guidelines, review some of the recommendations, and then I want to end with some take-home messages, some things that we can do to help with their implementation at the local level. It's one thing to spend a lot of time creating these documents and pushing them to publication, but it's another thing in terms of how they're disseminated, and how they wind up in the hands of the people who are affecting change at the local level. But with that said, and I appreciate Floyd and Jim this morning being on the spot and showing us their CPB prowess early in the morning during the conference. I'm sure that's not what they expected when they signed up to come to this meeting. I know that's probably the largest audience I had ever, had to pump in front of. But nonetheless, I want to shift gears a little bit and perhaps get you guys involved. So I have some ARS questions here. And hopefully this poll is activated. Now, if you see at the top of the screen, you can participate in this poll via one of 2 ways. The first one being if you just opened up your browser on your app of your phone, and if you go to pollev.com/DaveFitz, that will activate you into the survey. Or if you just send a text message to 37607 with just Dave Fitz, you can do it through your messaging services as well. So I'm going to let this play out for a few moments just to make sure that everyone has time to participate. I want to see what the denominator is. And I also understand that there's about a 20-second delay in the virtual audience. So if I leave this up a little longer, that's only for the purposes of making sure we get engagement from our virtual members. So the first question is, are you a coffee drinker or a tea drinker? I love watching how these things change. It's like the horse race, and it will tell me not only a little bit about you, but perhaps how much caffeine you've had now that we're approaching the 9 o'clock hour. And we always have a few that don't drink either. We'll let this play out just for a moment. So there'll be a couple questions like this just to make sure that people are able to log in, there aren't any technical issues. And then, I will ask you some questions about the impact of the guidelines, particularly on your practice. So we'll give this just a few more seconds to play out here. 44 so far. Looks like tea's falling by the wayside here, so a lot of coffee drinkers in the audience. I think I've become impervious to coffee, being a perfusionist for many years, just like I'm sure some of you can drink a cup of coffee and then go right to bed. Okay, so looks like about 53, 55, get some last second responses here, great. I'm going to go ahead and go on. That might be our virtual audience now that's connecting on. But I'm going to go ahead and go to the next question, which is, do you prefer cats or do you prefer dogs? Or are you not a pet person? How about both? You can't have both. You see how I bias this, Luke? Yeah. You have to pick one over the other, dogs or cats. So far, we look like coffee-drinking dog lovers. In full disclosure, I have 2 dogs myself, and I'm allergic to cats, so if I prompted this question with any bias, now you know why. Okay, 75, we're getting there. All right, last test question here for you is, do you like burgers or do you like tacos? Burgers or tacos? So I am in full disclosure, a fish taco enthusiast. If I gauge the effectiveness or how good the quality is at a restaurant based on how well they make their fish tacos, whether it's breaded or unbreaded, mahi, cod, even shrimp, you name it. We love fish tacos where I work and live in Charleston. Okay, good. So we're a bunch of burger-eating, dog-loving, coffee drinkers. I like it. I probably fit in that category as well. All right, so that being said, what I want to ask of you now are specific to the guidelines. So let me know if you're aware, first, that the STS guidelines for blood management exist. At least the 2021. You've probably seen the former iterations, but are you aware that the newest revision of the STS guidelines was published just about at this point last year, so it's been published for about a year now. This is also going to help me too in terms of the direction of this presentation as I go through some of these recommendations. If the majority of you know these guidelines exist, then I'll spend less time, of course, talking about them and more about potentially facilitating implementation. And yes, it's okay to be unsure. All right, so it appears as if 2/3 of us, at least in the audience, and those participating virtually are aware that those guidelines were published. And please note that this is all anonymous, it's de-identified. I don't know who you are, so if you could answer truthfully here. Well, we have an error. Well, no, I guess not. Have you read them? So you know they exist, at least 2/3 of you do. Have you actually read the document? Okay, so a majority have So it's what that says to me is that we don't really have a problem in terms of the messaging to let you know they're available. Perhaps what we need to do is a better job of facilitating engagement, right? That these, this is how this document can be interpreted and potentially applied at your level. Okay, 2 more, and I promise I'll let you put the phones down. So this one is, was a discussion had at your institution, whether it was just in your perfusion department or as part of your larger cardiac service line, about the guidelines, that these guidelines were published, they were multidisciplinary, they were co-published across 3 journals, so they were published in JECT, they were published in Anesthesia and Analgesia, and they were published in the Annals of Thoracic Surgery. And the purpose of doing that is to make sure that all the members and key stakeholders of the operating room all had access to that particular document through their own respective journals. Okay, so this answer is kind of aligning with reading the document, right? A majority of us haven't had the opportunity perhaps to discuss these as part of a larger team. And part of the emphasis that you'll see in this document, it was really designed to be multimodal but multidisciplinary. Everyone has to be a key stakeholder. There's not one home run therapy in there that says, hey, if I do retrograde autologous prime, we'll never need to give blood again. It's more of a combined multi-pronged approach in how we challenge blood management. Very last one here. My team made practice changes according to the 2021 guidelines. And I presume I probably have a good answer as to what this is going to result in. But again, it's one thing to create these documents. I was fortunate enough to serve with Al and with Rob Baker, with Tim Dickinson, to be the representatives of Perfusion in these guidelines when this task force was developed. And it's one thing to spend the time to create them, but they really need to be written in a way in which they're actionable, right? That you can take these recommendations and consider applying them at your institution. If they're just nothing but a bunch of words, they're really not going to have the impact. And this particular document, as you see, is 3 years in the making. So it's refreshing to know if these are written, is there an opportunity to see those positive impacts made at the local level? So a majority of us haven't made practice changes, which is, I'm not necessarily saying it's bad. Perhaps you've made changes based on the 2007 and the 2011 guidelines, and this was really either a way to confirm what you're doing or at least for you to reconsider the things that potentially you're not doing. So I don't have to talk to you about blood transfusions. They're life-saving modalities, of course. When we transfuse blood, it's for the purpose of improving the quality of care in the patients that we serve, but also have to be very mindful that it's not an innocuous procedure, and it carries with it inherent risks, as you know, with infections, prolonged length of stay, increased morbidity, and so it's almost kind of that damned if you do, damned if you don't thing, right? Is it better to, if the patient needs to be anemic, is it better to be anemic, or is it better to transfuse them while anemic? Well, if we can avoid both, that would be great, but in some instances, that's not possible, right? So we have to identify when people receive blood, is it because they really need the blood, or is this more of a discretionary usage? Are we using, the best available evidence to determine who best benefits from a blood transfusion, of an allogeneic blood transfusion? And as cardiac surgical clinicians, we're big consumers of the blood donor pool. We consume about 20% for our cardiac surgical population. And the availability of blood waxes and wanes regionally. We had seen during COVID that there were pretty severe restrictions in terms of the blood availability because people weren't able to get out there to donate blood. And even though that our cardiac surgical volume had been decreased because of the COVID-19 infection, had it not been, we would have run out of blood in many of these parts of the country. They were just working on, just a few days of available supply to treat patients. And that was one of the things that we worried about in the beginning when we were going to put patients on ECMO, that, gosh, do we actually have the blood available to treat them if they become coagulopathic? And we also know that there's a lot of variability in terms of how blood's transfused. And these are just 2 studies. They're several years old right now, but they're looking at a fairly homogeneous population, which is isolated CABG, right? This is probably the most homogeneous population that we serve in cardiac surgery, primary isolated CABG procedures. And as you can see here from the Bennett and Guerrero paper, there was variability in terms of red blood cell transfusions from 7 to 92.8%. Some programs were transfusing as low as 7% of their patients when others were almost 100%. So, conventional wisdom says, well, it's because my patients are older, my patients are sicker, they need to have blood. In many cases, that might be true. But when they adjusted for things like geographic location, they found that to be statistically significant. So based on the area that the hospital serves, there's a difference in transfusion rates. Or the academic status, if you were a university hospital versus a community hospital, or even the hospital volume, smaller versus larger hospitals, there were differences in transfusions. However, if you combine all these factors, it only accounted for about 11% of the total variability in transfusion. So there are other factors that are present that perhaps we're not sensitive to. And it's not just endemic to the United States, this happens worldwide. So the whole goal of clinical practice guidelines is for us to develop systematic statements to assist you and I and everyone else as practitioners in making the appropriate decisions on when should we transfuse, when should we consider transfusing, or what some of the things that we can do to potentially reduce somebody's risk of receiving a transfusion. And it's really important, if you were to look at this Venn diagram here to the right, that this isn't cookbook medicine. This isn't, I have to go based on this recommendation and I have no input whatsoever in terms of my clinical expertise or what our experience has been. It's actually a combined approach where we want to find ourselves, if we're practicing evidence-based medicine, to be somewhere in the middle here. What does the guidelines tell us? What does the best available clinical evidence tell us? What does our clinical expertise say? And then what are the values and the principles for the patient and their preferences? If we can combine all those elements, then we're more likely to have an evidence-based best practice approach to blood management. So, and we have plenty of tools that are available. It's, blood conservation guidelines are really still in their infancy, but now they've been available since 2007. So the landmark publication in the Annals, which is the most cited document in all of the annals of thoracic surgery, are blood conservation guidelines. And in 2007, the landmark document that was published consisted of 57 unique recommendations on cardiac surgical blood management. And this was co-authored by members of the STS and the Society of Cardiothoracic Anesthesia. But since then, there was an update in 2011. Other societies, both here in the United States and abroad, developed their own clinical practice guidelines for blood management. So now we're 14 or 15 years into this. We have an abundance of data to reflect on, to determine for ourselves how can we take these guidelines and create protocols that are specific to our programs. And I think it speaks to ensuring that we understand how these documents can help us. So after that 2007 set of standards, this was a survey that was sent out to perfusionists and anesthesiologists across North America. So there were about 1,400 respondents. And the questions were the similar questions that I asked of you in the ARS is, did you read these documents? And then two, were these documents successful in instituting change at your facility? And you can see, based on the results, this was 3 years after the publication of that document, that about 20 to 25% of the perfusionists and anesthesiologists said, yeah, we had a discussion about it, and yes, we made change. So it was a minority. So to us, as people that spend some of their volunteer time in serving in these guideline writing groups, it really told us that we need to do better. We need to do better at getting the message out. We need to do better at creating tools to facilitate their adoption. And three, we need to be responsive in how we do that, how quickly we can update these documents, because the last thing you want is to be using guidelines and standards that are 15 years old. So this is an investment of time and resource to continually improve and update these documents as new published information becomes available. So as I said, after that 2007 publication, in 2011, they updated the document, and this time they included perfusionists. So after that 2007 document, there was a letter to the editor of the Annals to say, hey, it's great that surgeons and anesthesiologists are working together now. This is great, but you're missing a pretty important person in the operating room that influences blood management. It's the perfusionist. So they were very open to inviting perfusionists. So there were several perfusionists from our community that participated in the 2011 document. Not only does it make it more comprehensive, but there's representation that now can go back and speak to their organizations. And so this was updated in 2011, and then several years had gone by. And so when the STS decided to update this document in 2018, they went by the same process, but they even wanted to be more inclusive. Now they involved not only these three societies, but the Society in the Advancement of Blood Management, which is a professional nonprofit organization that has a multidisciplinary membership of key stakeholders, all focused on blood management. So the structure of how this document was designed This is a pretty exhaustive process, and the STS fortunately has the resources to be able to assist, because with surgeons and anesthesiologists and perfusionists who are all volunteering for this work, the amount of time that we can put into it is fairly limited, because we all have our own respective responsibilities with our positions. And so they had 2 full-time people from their headquarters working to help facilitate, to do all the literature searches, collect the documents, provide the documents in a systematic review, so it was easy for us to be able to synthesize. So they developed these PICO questions. If you're not familiar with what a PICO question is, it's a question that's systematically designed that includes the patient, what types of patients are we looking for, what the intervention is, what are we comparing, a comparator, and what the outcome is. So it helps us in terms of directing our literature search. And so after these 11 PICO questions that were related to cardiac surgery were developed, the initial literature search brought back about 1,200 papers. We were fortunate enough to be able to filter those down based on whether or not it was specific to cardiac surgery, whether or not there was a clinical outcome marker reported. And so what we wound up with is about 87 papers that really provided the framework. So what you'll see in this document, if you haven't read it already, is there's 23 new or updated recommendations. So a far cry from the 57 or the 61 in the previous documents. However, there were also a series of recommendations that were voted on that weren't really part of the evidence base, but we thought were pretty important to ensure that this was still pretty comprehensive. And so as we go through these, you'll see the topics that are here. Of course, perfusion interventions is our wheelhouse, right? So these are the things that we can do directly in order to help with blood management. But I think what you'll see in these bullet points is that it's an entire continuum of care. From the time the patient enters the hospital to the time that they're discharged, everyone is a member and a key stakeholder in blood management. How many times have you been so frustrated that you want to be evidence-based, you want to make sure that only the patients that need blood get them, but your patient comes into the operating room with a starting hematocrit of 25? There's not a lot you can do there, right? To use a crude analogy, you can't get blood from a stone, right? There's only so many techniques that we can employ to avoid a blood transfusion, of course, unless we drop our trigger to 15%. And so it really starts the moment that the patient comes into the hospital. Minimizing phlebotomy, ensuring that we can try to optimize red cell mass. If they're really anemic, could they be delayed potentially with some iron and EPO supplementation to bring up their hematocrit? What are the risks involved in doing that? So, and over here to the right, this was a paper by Vic Ferraris and colleagues in 2015 this was a database through the American College of Surgery looking specifically at their quality improvement database. And this was about 470,000 patients. And they found that, the patients that had the highest mortality and morbidity were those that were both anemic and transfused. So, is it better to, avoid anemia or to transfuse, or is it better, to be anemic and not to transfuse? Sometimes we don't have the ability to make that decision when they're profoundly anemic, but, again, it gets back to this, I'm damned if I do, I'm damned if I don't. So, and what also changed in 2021, different from 2011, is the structure of the classes and the recommendations. And so this was an update that was made through the American Heart Association, American College of Cardiology. And what you'll see here is traditionally for classes or strengths of evidence, you'll see class 1, class 2A, class 2B, and class 3. What you'll see now is that there's class 3 has been stratified to either, no benefit whatsoever or actually harm. So if you see a class 1 recommendation, that's a pretty strong indication that you should consider doing this, right? So you can see up there the benefit clearly outweighs the risks of doing it. A class 2A would say, yeah, the benefit outweighs the risk, in to some extent. A class 2B says, yeah, the benefit's, probably outweighs the risk here. But when you get to class 3, you can see, well, there's no clear benefit over the risks. And even in class 3B now, you can see, yeah, the risk actually outweighs the benefit of doing this. One of the ways that I think traditionally we've looked at this when these guidelines become available is that, let's look at the class 1s and 3s first. The ones said we should really be doing this, and if we're not, let's talk about why. The class 3s say we shouldn't really be doing this, and if we are, let's talk about why we need to stop. I think what's left to the interpretation of the end user is, what do you do with the 2As and the 2Bs that are, not as strongly in one direction, one way or another? So I think those are some of the things that are open to interpretation at your facility. And then the other thing, too, is this time around, we had the benefit of using registry data. So when you see a level A recommendation that says, this recommendation is supported by multiple randomized controlled trials that have been performed, and they're high-quality randomized controlled trials, and they're meta-analyses, and there's a lot of evidence in the literature base to support it. Level B would say, you might have a randomized controlled trial, but a lot of great observational studies. And level B and R is new, that says, there's great observational studies. They're not randomized. And, now we can use registry data. So the STS registry has millions of patients in it. And perfusion registries now have hundreds of thousands of patients in them. And what can we take from that data to help us in terms of answering questions about the care of patients in cardiac surgery? And then level C is a lot of, limited data with, perhaps weak studies or even expert opinion that, there aren't going to be many randomized controlled trials that show that jumping out of an airplane without a parachute is bad for you, right? No IRB is going to approve a study where people, we're going to have this group jump out of an airplane with a parachute, this group not have a parachute and jump out, and let's see what the outcomes are at the bottom, right? You're not going to get that study. We don't need to do a randomized controlled trial to say that parachutes are effective. So in many cases, you'll see it might be just expert opinion. So I know this is a little bit of eye candy and hard to read. These were the previous recommendations that were revisited, not part of our evidence base so much, but voted on by the group. So we did series of rounds of voting each time that we reviewed this. So I guess the one thing that I just want to point out here is modified ultrafiltration. So in the 2011 guidelines, modified ultrafiltration was a class 1A recommendation. It says, for adults, you should really be doing it. However, in the 2021, it's a class 2B. So you might want to consider it, but it's hard to see a clear benefit. So you would ask yourself, well, why is there such a change? Well, part of the change is, there might have been meta-analyses that were conducted, but the heterogeneity of the study designs, weren't very good, that the sample sizes of these studies were fairly small, and it actually included some pediatric patients. And as we know, MUF is really popular in pediatrics, however, not so much in adults. And so the group thought it was warranted to back that recommendation back to a 2B. And I don't know, by show of hands, does anyone do MUF here for adults? Okay, so for those in the virtual audience, no one raised their hand except for me. I don't do it. I was just, trying to play along here. But oftentimes you don't have an adult cardiac surgeon that wants to wait that long to give protamine anyway, unless you're the surgeon that was up here asking for protamine with pump suckers, but I'll have to talk to him later in the hallway. Okay, so I'm not going to spend a lot of time going through each bullet point, maybe picking a couple out, perhaps things that have changed over time. So these are the preoperative interventions, right? The things that happen before you see the patients in most cases. A couple of the things that I'll point out here is that for patients that are already anemic, that are red cell mass depleted, there are some recommendations that are 2A level to suggest, either some level of iron therapy or erythropoietin stimulating agents. when possible, to try to stimulate red cell mass. Probably more evidence in the combined approach than using just iron alone. And the other thing I think is important here is minimizing phlebotomy, right? You know, if a patient spends 3 days in the hospital as an inpatient before they come down for surgery, you know, how many blood draws are taken? You know, it might seem like a little bit when they pull the sample or they waste some, but over 3 days, you know, that can become more cumulative of an effect. Or if they have an IV that's inserted, you know, you always have to see the drip chamber running, right, so that the patients become hemodiluted when they're in the hospital. Antiplatelets, so we're seeing a lot of usage of dual and single antiplatelet therapies, and for us in the audience here, many of our patients have to wait for some of those ADP receptor, you know, P2Y12 blocking agents to reverse or to wane before we can operate on them. So you can see there's a strong class 1 recommendation for waiting 3 days for ticagrelor, Brilinta, clopidogrel or Plavix for 5 days, and then prasugrel Effient for 7 days. But that's not always feasible to wait if they're emergent. So the next recommendation that you see here, which is a 2A, is or the third one down, I'm sorry, is laboratory or point of care testing. So do you do platelet function testing or some type of viscoelastography to be able to identify whether or not they're still inhibited, you know, with ADP receptor agonists, you know, to determine whether or not it would be safe to be able to operate if you're unable to wait. This is an update from 2011 because we're seeing much more usage of, you know, the dual antiplatelet therapies as opposed to what was happening, you know, circa 2009. Preoperative anticoagulants, same thing. You know, we're seeing more patients now with novel non-vitamin K oral anticoagulants, such as dabigatran, which is an oral direct thrombin inhibitor, as well as some of our factor Xa inhibitors. And subsequent to that 2011 document, now in the marketplace are actual antidotes or reversal agents if we're inclined to have to reverse those. So those have become commercially available, I think, since 2015. And if it's not available, you know, as an antidote, perhaps even considering prothrombin concentrates. So we're seeing a lot of mixed and concentrated isolated factors for reversal. Pharmacologic agents, again, lysine analogs like tranexamic acid, aminocaproic acid, Amicar are class 1 level A recommendations, a lot of solid evidence in their usage. Even tranexamic acid used for off-pump CABG surgery, which I found interesting. And then a statement here with a class 2B, a weaker recommendation for the use of desmopressin DDAVP for patients with von Willebrand's disease. Blood products and derivatives, more recommendations here, of course, with regards to antithrombin concentrates. So if your patient in the operating room is unresponsive or not strongly sensitive to heparin, you know, you give the heparin, ACT comes back below 400 seconds, you give another, you know, another full dose, doesn't come back again to meet your target. You know, are you inclined to ask to have the blood bank thaw FFP? Do you have AT3 concentrate available to give? You know, you have a surgeon that wants to go on bypass, that's ANSI, so a class 2A or class 1 recommendation if you do have availability for lyophilized concentrated AT3. Prothrombin concentrates, again, as a first-line therapy of refractory coagulopathy. Factor 7A concentrates, Nova 7 for intractable non-surgical bleeding, weaker level of evidence, of course, based on some of the trials and some of the risks of giving that, and not giving prophylactic use of plasma in cardiac operations when, you know, the absence of a coagulopathy is not indicated. Here's your wheelhouse here, so we'll spend a couple minutes on this with perfusion interventions. So in the 2011 recommendations, we had a 2B statement, a 2B recommendation for RAP. Now that is now a 1A recommendation. There's been a few randomized control trials and really good, strong observational studies supporting its use. So retrograde autologous priming, class 1, level B, randomized recommendation. And then reducing prime volumes. There's some great data that's been published just within the last few years, one of which came out of the Perform registry, Tim Dickinson and colleagues looking at net prime volume. So your net prime volume, as you know, is your static prime volume minus your RAP volume. So what's the effective crystalloid volume the patient will see when you start cardiopulmonary bypass? And they found, a great quality improvement project across the state of Michigan with decreasing their net prime volumes to 500 or below. So if your static prime volume is 1,000 or 1,200, that you're taking 500 to 700 of RAP, patients only seeing about 500 of that, minimizing hemodilution. And then the other 2B recommendation, which is now a 2A, is acute normovolemic hemodilution, or ANH. So you're harvesting blood prior to heparinization, at least maybe helping facilitate with anesthesia from the central line, and reserving that blood to have available as soon as they terminate bypass and reverse with protamine. So the patient's essentially getting their own units of blood back. It's a cost-effective way. There has been a few studies, one larger study from meta-analysis from Burrill and colleagues, and some observational studies, once again, from Josh Goldberg and colleagues. And I think Al had co-authored a great study out of the SCOPE Specialty Care Database, actually combining RAP and ANH together, because if you're going to take ANH blood and replace it with an acellular fluid, patient's going to become a little hemodiluted. So you may be more inclined to have to RAP in order to adjust for that, to make more candidates available for ANH. Here in the United States, we don't have as much of an experience using mini circuits or MIAC circuits, not like they do in Europe. I think there might be a talk later on, if I'm not mistaken. And again, as I mentioned to you, modified ultrafiltration is a 2B. And then just finishing up here, blood salvage interventions, auto transfusion or cell salvage, still a class 1 level A recommendation. But you can see here at the bottom a class 3 recommendation with harm for the process if the patient's shedding blood from the mediastinal chest tubes, to try to process that and reinfuse it back into the patient. And then postoperative fluid management, considering the use of albumin. Albumin is a colloid osmotic agent to minimize the amount of third spacing or crystalloid that's lost through the capillaries into the tissues, and avoiding the use of hydroxyethyl starches that make platelets dysfunctional. We've seen a lot of that data over the last decade or so. Transfusion algorithms, having a transfusion algorithm. What is your threshold for transfusion? There's been a series of papers for the TRICS and TRACK studies demonstrating that a restrictive transfusion threshold is at least as safe as a liberal one, and you use far less, significantly less blood products to do it. So there is evidence for, allowing your hemoglobins, most of those studies were hemoglobin thresholds in the restricted group of between 7 and 8 grams per deciliter. And then a class 1 recommendation for viscoelastic devices for point of care testing, for, guiding you in terms of if they do need a blood transfusion, which particular fractionated product is most appropriate for this patient. Not that, shotgun therapy, if they're just going to get a little of everything. Let's try to really be quantitative with how we decide if and when they're going to need a transfusion. And then lastly, this I think really speaks to the reason why these guidelines exist. And it's because, we want to have a multimodal blood conservation program that's multidisciplinary. Everyone has to be engaged. You can't have, surgeons that are very aggressive at implementing blood management without their colleagues, anesthesiologists and perfusionists, becoming part of the team. Blood management is a team sport. And for perfusionists, this is right in our wheelhouse. There's few professionals that are as formally educated in blood and blood management as perfusionists are. So if you have opportunities to serve in a leadership capacity at your institution in this regard, please raise your hand. You have a wealth of information and experience to share, and you can really impact and make changes. Which leads me to my last couple slides here. So these guidelines exist. They've been published. Some people read them, some people don't. Some people implement them to their practice. But really what we have to get down to is what drives transfusion variability. Why is it that one program has a 7% transfusion threshold for CABG and another one is 92? The guidelines exist. They're there for everyone. They're publicly available. What can we do, to help those programs at the local level? So this was a study that I was involved with that was published last year, looking at, identifying the characteristics of what drives variability in transfusion across hospitals, right? So we looked at these 45 centers across the Perform Perfusion registry and looked specifically at isolated CABG and wanted to identify what drives variability between hospitals, right? And conventional wisdom says, well, it's because, my patients are older, my patients are sicker, they're more anemic. Well, if that's true, if we adjust for all these things, we should be able to see that everyone has the same transfusion threshold if we control for that, right? This is what's called a turnip plot. A turnip plot is an illustrative graph that's used a lot by Dartmouth's Atlas of Health to look at variability in public health measures. So if I show you this here, so think of this, if I turn it on its side, it's a histogram, it's a bell-shaped curve, right? So here is transfusion. So you can see there was each little center, each little dot is a hospital. So you can see there was a hospital that only transfused about 10% of their patients. And then we had another program that transfused about 60% of their CABG patients, okay? And each little dot here across the horizontal axis are centers that transfuse about the same rates. So you can see there's a fairly decent spread here. So what we said is, okay, let's adjust for the patient. So all of their, chronic conditions, their labs, their starting hemoglobin, their starting platelet counts. And then, so we'll take all the patient factors. So if your patients are truly older, sicker, and have more chronic conditions, then we would see, if we adjusted for those, that this line would just be a single horizontal line, right? And you see it's not. In fact, the coefficient of variation didn't change very much at all. So, okay, well, maybe it's not patient-driven in terms of variability. What about perfusion factors? If a perfusionist wraps, if they do A&H, if we use cell salvage, if they have a net prime volume under a certain threshold. And again, it wasn't that. It wasn't perfusion-driven either. There was still variability that existed. And then we said, okay, let's put it all together, one big bucket, right? Let's adjust for everything. And we should have this one line straight across. We're done the study. This is great. We're back to really where we started. So this told us that this null finding was actually a finding, that at least in this analysis, it's not driven by the patient necessarily. It's not driven by the interventions that we use. And it's not driven by laboratory factors. So what drives variability in blood transfusion? I should have had this as a survey question. Remember to do that. Really put you on the spot. So the things that we can't measure, we can't consider, might be non-clinical factors, like an organizational culture, right? Or whether or not you have a blood management protocol. Do you transfuse based on a protocol? And if that protocol exists, what about the triggers? Are there triggers that exist? Team familiarity. This is an important one, right? I was talking to somebody this morning, and their cardiac service line has 48% travelers. How many people are using travelers in their program right now? Yeah. It's a likelihood that working as a team, you're very familiar with how everyone works. There's a lot of moving parts coming in and out, and So does team familiarity have a part? This was a study up in Providence, up in the Pacific Northwest, of looking at 12 hospitals within the same system. So these surgeons served all 12 hospitals. And they found that with variability of transfusion, 30% of it was attributed to the surgeon. 70% was attributed to the institution. The surgeons don't change their transfusion practice from hospital to hospital. It's the culture at that institution. And this was in Michigan, looking at hospitals that do caths and open heart surgery. And what they found was that if the programs that transfuse more in cardiac surgery also were the ones that transfuse more for cath lab. Now, again, a much smaller scale. You don't transfuse 60% of your patients in the cath lab. But if you were more inclined to transfuse in the cath lab, you were more inclined to transfuse in cardiac surgery. I don't know. It's an interesting find. And I think what's really important is that we collect these things. So the Perform registry did with their 2018 update, now when you fill out their registry, they ask for, okay, what was the hematocrit at the time you transfused? And then which of these conditions apply as to why you transfused? Was it purely based on hematocrit, or was it because you had low SVO2, or you just, you were sucking dry in your reservoir? What were the reasons? And so we need to better understand. We know when they're transfused. Now we need to better understand why they're transfused. So in summary, what I'd say is, clinical practice guidelines are really conceived as an all-inclusive, protocol-based and shared decision-making approach. But if they're not uniformly applied, that these hospital influences at the local level will have limited effect on how individuals can practice using these guidelines. And that perhaps we really need to spend a little bit more time further investigating, the non-technical aspects of transfusion medicine. So with that, I thank you for participating in the ARS this morning, and I don't know if we're going to have questions or not. I'm happy to answer any questions if we have time. Thank you.